and we can. This is the program of the BIT Breakthrough in Intervention webinar on BIT Breakthrough in Intervention. This name was given by Sanjay Karla this time. This name is not given by me. This name is given by the Sanjay Karla, and I said that I will try to set up an webinar, BIT webinar on the complex PCI. Then say that what about the BIT Breakthrough in Intervention? I think it's an excellent name that was given him. I must congratulate him. So with us we have an Ravin Chakraborty, one of the course co-director, and Mominujaman, Chief Consultant Union Hospital. It is really honor for us that he's working officially as a course co-director from BIT for the last year. And we have Shubhanan Rai, director of Fortis Hospital. He's also working as a course director since, and officially they are the actively involved in the BIT organization since its birth, but now they are officially involved from the last years. And my friend Sanjay Karla, he's a great interventional cardiologist, I will say that, and he's a director of the complex PCI, and associate director interventional cardiology and fellowship program, Einstein Hospital, Philadelphia, USA. And thank you. And last, not the least, my friend Dr. Nishina, he's a chief cardiology consultant and is a medical center. She is from Japan. The name is very difficult. He is also very much expert in the field of the IVAS and all the complex PCI. So, and with us, these are the panelists, and I am also working for the BIT. So, and let us start with the program. And Sanjay Karla, if you say something before the starting of you can say a few words about this webinar that we have given the name, why you have given the name of the BIT Breakthrough in Intervention. You can say a few words and then we start your presentation. And Momin Jawan is online? No. Okay. So thank you. And thank you all the participants that you are adding. We have 80. We have in Zoom, we have 80 participants, and Facebook, I am sure more than 200. So now the participant is around 300. Maybe it will be increasing more and more. Not only Bangladesh and India, throughout the country, people are joining this program because this has been broadcast each and every, especially Southeast Asia. And Sanjay Karla, can you hear me?
Yes, I can hear you just fine, my friend. How are you?
Okay, thank you. So here, these two people, young people, they are a lot of contribution of the BIT, especially in development for the SIP symposia as well as the imaging. Both of the guy has great contribution, especially in Bangladesh. I will say that. So thank you. And Sanjay Karla, can you start your? And would you like to?
Yeah, I'll start.
So Robin Robin sent a message that. Robin says that why it is a complex BIT breakthrough. Why complex?
No, why did I pick breakthroughs in intervention? I guess I'll get to that in my talk. I think I noticed that what you had put on was new ways of dealing with calcium and new ways of assessing lesions using intravascular ultrasound. The reality is, even though these problems have been around for a long time, our adoption of the technologies and the techniques to actually deal with them properly is quite poor. Even out here in the US, where we've had Ibis on a regular basis for many, many years, only 12% of people actually 12% of operators across the country actually use it. And so it's time to reinvent the way we do things, recognize that the patients that we see in today's cath lab are more complicated than the ones that we used to see. And as a result, use all of the techniques and technologies that we have at our disposal to achieve optimal outcomes. And that's hopefully what I can impress upon you over the course of some of my talk in the next few minutes. I'm just going to try to share the content here that I have. Okay. Can everyone see my slides?
Yeah, yes, you can see your slides. Go ahead.
Yeah, great. Thank you. So the title of my talk was "What is complex and high-risk PCI?" or "What is CHIP?" and what's the nature of the training that I need? CHIP and complex and high-risk PCI has been around now for a few years as a sort of specialty area or subspecialty area within interventional cardiology. You've seen many good webinars and seminars put on by Dr. Aman and Dr. Chakraborty and their colleagues throughout both Bangladesh and India to educate the community on the types of procedures that comprise the CHIP subset. But I think having done this now for a few years and having been an early adopter in the field, I'm realizing that it isn't really what we thought it was. And I want to make that clear here. These are my disclosures. So the reality is our patients are getting sicker. When you look at this cohort of over 2.7 million PCIs from the NCDR, over the past several years, we see that the nature of our patients is fundamentally different. They present with worsening angina. That number has almost doubled from 16 to 38% of patients within this large registry. And there's a large number of patients, almost a 50% increase in patients presenting with high-risk findings on stress test. Interestingly, the number of acute PCIs that we do are about the same. So it tells you that it's in fact the stable angina or the stable coronary disease subset with background disease that is then tipping into more severe problems that is really growing, as opposed to the soft 10, 20, 30% lesions that suddenly rupture. And that suggests to you that maybe these are the individuals who have coronary disease already, who then are presenting to the cath lab with worse and worse phenotypes. You have to ask yourself, why are they suddenly presenting with worse phenotypes? The reality is that there's data to back that supposition up. There are more type C lesions that are presenting to the cath labs. The numbers of calcification between 2006 and 2011 has grown by almost 8%. And so that may be because patients are sicker when they get to the cath lab. When you look at this cohort of patients between 2004 and 2014, so over 6.6 million PCIs, you see that the number of people with a Carlson comorbidity index, so severe comorbidity burden, back in 2004 was only 6.3% of patients, so roughly 1 out of every 20. And that's totally different now. Now it's 1 out of every 7 or 14% with Carlson comorbidity indexes of over 3 in 2014. So over this period of time, and this is an observed trend right across all of the comorbidity subsets, you see that over time, the patients that are getting to the cath lab seem to be getting there when they are sicker, when they have more kidney disease or more hypertension or worsening diabetes. And when you look at this group from the Framingham cohort, you might see why. In 2009, the number of patients who had what we would consider high-risk phenotypes was only about 20%, whereas in 2015, it was 25%. And that's because in 2009, they were younger than they were in 2015 when people were presenting. So in 2009, the average or median age of presentation at the cath lab was 63 years, with a range of 59 to 71. And in 2015, now we have a growth in that up to a median age of 67, with roughly the same sort of range presenting to the lab. So you start thinking about what that means, and I suggest that as patients get older, they get sicker, because we do a really good job of making people live longer, but maybe not such a good job of making them live better. And as a result, even though medical therapy certainly works, we are, with the various things that we do to risk reduce, deferring disease to later on in life. And this is good because people
He has gone to mute. Dr. Afzalur, Sanjog is mute.
So yeah, so the point is that the mean age across years is increasing dramatically, right? Where we've gone from 63 in 2009 up to 67 with a similar range. And the reality is that because the range is the same, but the age is going up, and coronary disease hasn't miraculously changed in its composition, it's probably because patients present later to the lab with their stable disease. Medical therapy works. You get longer periods of good quality of life. But the flip side of that is then when you eventually present with coronary disease, because this is a disease that is a function of age, the disease that you present with is more severe. And so when we think about the CHIP subset, the complex and high-risk PCI subset, we think about this age-old Venn diagram, right? This combination of very advanced age and multiple comorbidities, ventricular hemodynamic dysfunction, and then the complexity of coronary disease and anatomy and distal targets. But this doesn't really tell us what complex and high-risk PCI is. This gives us a general idea of the types of patients that may need these procedures. And so when you combine these three Venn diagram areas, you get this central area where there's the overlap of all three of these characteristics. We conceptualize that in our heads as somebody that's probably a CHIP type patient, but we need to parse this out a little bit more. We need a more concrete example. And the best concrete example is probably available through the surgically ineligible patient. Now, when we look at surgically ineligible, what do we mean? Well, we look at this cohort of people that was recently studied by Waldo and his group in Boston, and we look at the reasons people were turned down for surgery. We find that only 35% of them are because they're old. There's a large number that are because there are poor conduits, but the majority are because they have really bad comorbidities: renal insufficiency, severe lung disease, severe systolic dysfunction. So they're sick patients, but do they actually do any worse? Well, when you compare those who are surgically ineligible versus those who are surgically eligible, you see a 6-fold higher increase in mortality by hospitalization end. So these individuals are very sick and they are at high risk of doing poorly. So the reality of this Venn diagram is that this is not complex and high-risk PCI. These are just the characteristics of complex and high-risk PCI patients. So some patients have ventricular hemodynamics with no coronary disease, but advanced comorbidities. Some people have advanced age, bleeding, and CKD with a normal left ventricle and an unprotected left main. Which of these is CHIP? Which of these is not CHIP? Well, if you recognize that these are all characteristics, then as part of that, you probably recognize that not all procedures or patients or operators are equal. These are 3 different procedures. The one here in the upper left-hand corner is a mid-LAD CTO and somebody with an EF of 15% on a hemodynamic support device. That's different than this heart on the upper right-hand side that's barely moving because this patient is in severe cardiogenic shock on ECMO and has a distal left main bifurcation with an occluded ramus. And that still is different from this completely normal ejection fraction, but post-bypass long right coronary artery chronic total occlusion with separate occlusions in each of the distal branches of the RCA, right? So these are 3 different cases. All 3 of them are complex, but which one is more complex than the other? Which one is truly CHIP? Which one is not CHIP? Which one is safer in your hands? Which one is not safer in your hands? This graph on the left side from the Syntax trial, I think, illustrates how this variability is germane, where if you look at this sort of white bubble, if you look at the white bubble on the right side of the graph, I would submit that nobody wants to have their cabbage done at that site, no more than they want to have their PCI done at the site where your Taxus stent MACE is above 50%. And so if procedures change and patients change and operators change, then what is CHIP? I thought it was a complex procedure. Well, it's not a procedure at all. We think about revascularization data and PCI metrics. We think about understanding complex anatomy, how to manage large bore access, how to manage complications, ventricular hemodynamics, PCI, CTO PCI skills, and the like. And then we parse those out even to more granular skill sets to recognize that CHIP, or complex and high-risk PCI, is in fact a skill set. It is this woven tapestry of smaller skills that becomes a larger skill set upon which operators can draw at any time whenever those skills are necessary to be used. And does it work? Does it work to have these skill sets? Well, what we see is that in the most complex of lesion subsets, so chronic total occlusions, even those with ventricular dysfunction, that as you do more, as you practice these skill sets more, as you have more volume, you get better and better with higher success rates, and you get lower and lower MACE rates. So if the skill set is what complex and high-risk PCI is, and there are so many little skills, how do you collect these things? How do you get the skill set that you need to be ready to deal with whatever's coming through the door? My case on Monday was a lady who had chronic kidney disease. She was only 70 years old. She was talking to me and was otherwise perfectly fine, but was in cardiogenic shock. Her blood pressure was 90 on 70. She was tachycardic. And when I did the beginnings of her femoral access, I realized I couldn't feel any pulses. Then when I put the fluoroscopy on, I realized that she had stents in both iliacs. And I finally used a micropuncture kit to get access, took a picture of the coronaries, and realized that the right coronary artery was severely diseased, as was the entire left system, but everything was extremely calcified with a 95% distal left. Her EF was 10% on a V-gram. And to make matters worse, she had critical aortic stenosis where I had troubles putting a pigtail catheter across. So is this a CHIP patient now? Well, does it add to the fact that it's a CHIP patient when I realized that both of her iliacs were occluded and I needed to intervene on the iliacs in order to get a support device up, in order to atherectomize, in order to then fix the right coronary artery, only to realize that she had a retroperitoneal bleed from this shutdown, from this horribly calcified iliac, where I had to then coil the femoral artery. The idea is that all of those skills need to be quickly available to any operator to be able to manage these types of problems. And so how do you acquire this global skill set? That's a really difficult task. Well, when we think about today's training pathways, there are really two that are reasonably well established. There's the dedicated CHIP fellowship training that I get inquiries on a fairly regular basis. And then there's the on-the-job emerging leader type track that most practicing interventional cardiologists that are interested in this space are familiar with. So the dedicated fellowships are aimed at trainees who have recently or often immediately completed interventional cardiology fellowship training, so that they're sort of pre-bad habits. The fellowships aim to recruit highly motivated and technically proficient fellows who are willing to put themselves to a dedicated, very intensive training program that's aimed at developing the full complement of these types of skills. But the challenge is that how many centers do you have anywhere in the world that can actually supply a trainee with enough attending physicians who have the experience to be able to teach the entire skill set, and with the volume necessary to be able to practice? As trainees, we make mistakes. We need time to develop our skills, particularly when those trainees are early coming out of fellowship. So huge volumes of these types of procedures and a tolerance for complications is necessary. And that's why this is a very difficult way of acquiring these skill sets. It's possible, it's very successful, but it's challenging. And so the majority of people are actually acquiring the skill set using the on-the-job training pathway, where we're aimed at sort of highly committed practicing interventional cardiologists who demonstrate a gradual growth in their skills. And it's fostered by intensive self-directed learning and partnership with colleagues in industry, attendance at these types of webinars, at meetings like BIT or CHIP CTO India or Sing Live or what have you. But the challenge is, once again, that it requires an individual who's already got a very busy practice to come out of their practice and dedicate the time to learning these new skills and then bringing them back into their practice, practicing them, and then being proctored and vetted on a regular basis. So the current training paradigm requires a little bit of help, right? It requires more investment from us as operators if we're going to be doing on-the-job learning, and more investment from our institutions to be able to give us the room and the resources that we need to succeed. So if we need to understand that that's where to go, then let's look at where we've been. Let's look at somebody who's done that kind of thing successfully. Let's take a page out of the trauma book and what it takes to create a trauma surgeon. Trauma surgeons, much like CHIP operators, train in unique individual skill sets that are combined to create an acute care surgeon. They're experts in elective surgery, and that's what they do most of the time. Kind of like us. We don't do CHIP PCI every day. We do the standard stuff most days, but we're ready to take on these more complex cases when they come up. They then train in emergency surgery, how to do the standard stuff, but very, very quickly, sort of ST elevation, MI, shock training, these kinds of things. So all stuff that's a part of fairly standard training, but that you get good at over time. And then on top of that, they put a specific bit of training in trauma surgery where they do emergency types of surgeries that are aimed at saving patient lives, recognizing where you can give up room, where you can't give up room, where specific techniques are necessary to achieve optimal results. And then to top it all off, they actually train in acute care medicine. They train in critical care medicine. And the combination of all of those skill sets is what creates an acute care surgeon. It's a complete skill set. And in order to do that, then, you need an institution that supports you. Trauma centers are organized by levels, for example. where here in the US, you have a level 1 trauma center that's responsible for educating the community, educating trainees, providing level 1 trauma care, so gold standard services with no need to transfer patients. And that's different than your level 3 or level 5 trauma center, where they do initial stabilization, the usual early trauma surgery, and then quickly transfer to higher levels of care. That requires a bit of a check of the ego at the door, doesn't it? Where if we recognize that our institution isn't willing to support us, then we need to get our patients, who are truly our priorities, to a place where they can be appropriately served. And so when we think about the complex and high-risk PCI skill set, we need to recognize that it's time for training standards, right? We can't just say that we know how to deal with complex anatomy, or we know how to deal with complications, and have no goalposts against which to measure ourselves. And this is the toughest part of complex PCI. This is the toughest part of accruing this skill set, having some sort of measuring stick or guiding line against which we can define ourselves to ensure that we are not only adequate to the task today, but we will remain adequate to the task tomorrow. And so this is the future. These are sort of proposed core competencies and targets within each area of CHIP training, going all the way from pre-CHIP or level 0, sort of the pre-contemplating, very good, very interested standard operator who does the usual PCI that we are all relatively familiar with, to those who have accrued some of the CHIP skill set, who recognize the importance of physiologic testing and who are experts with Ibis and OCT interpretation, and who can do antegrade wire escalation and ADR, CTO, PCI, et cetera, all the way to those who have moved on to a more advanced CHIP skill set, where they're dealing with the entire gambit of coronary disease, and where technical limitation really isn't a limitation anymore. And in order to accrue that skill set, you need an institution that will support you. So you need these sort of paradigms where institutions across large areas, large geographic areas, be that all of Bangladesh, for example, or sections of India, designate centers as level 1 CHIP centers, or earn level 1 CHIP type designations through providing the entire depth and the entire breadth of CHIP related treatments and CHIP related operator skill sets that are then tested and vetted on a regular basis. This is the next challenge. We as a community now need to take this challenge up and recognize that we recognize there's a patient population out there that's getting sicker and that really benefits from intervention, and they are much more difficult to treat than they used to be. But we now need to, as a community, define who it is that is going to benefit from the treatments the most, and how it is that we can get them the best outcomes as safely as possible. This is an example of one of those on-the-job training pathways, where maybe you take an interested interventional cardiologist who's nominated by their lab director to become a pre-CHIP trainee, who then registers in a web portal that we have conceived as a community, goes through a core curriculum and becomes sort of that level 1 trainee. The level 1 trainee then participates in a supervised knowledge gain and experience gain exercise, submits their cases for formal review, gets formal certification, and then moves on to level 2. And through similar skill accrual courses and similar on-site proctoring, they're able to achieve the entire CHIP-related skill set. So what is complex and high-risk PCI? It's a complex and highly developed skill set that our patients need us to accrue so that we are ready to meet their needs. It's not a procedure. It's a skill set that allows us to safely treat just about anybody that comes through the door. We have a couple of different paradigms that we can use to learn. And the most important part about the future is that we as a community need to rise up and commit to this and recognize that without standards, we're going to continue to spin our wheels, where every second day you see somebody on Twitter that says they do a great job in PCI, but they just don't tell you, what happens afterwards. As on a personal note, I present a lot more complications now than I do successful cases, because I find that those are the most instructive cases, both for me and for people that are listening to me speak. And I would encourage operators, all of us out there, to be willing to present those types of cases up front, because the reality is we all have them. If the only way to avoid complications, the only way to avoid bad outcomes is to not do any cases. And if they are the most instructive cases, the ones where we see what some of the characteristics of the CHIP subset can lead us to, then that's how we as a community develop ways to solve those problems and stay ahead. Thanks very much.
Yeah, I think it's a great talk. Abdullah, you think we can take up the questions after all the presenter? That would be nice.
Would you like to have a comment on this presentation?
I think we can take up all the questions and later on maybe.
Okay. Now can I thank you, my friend Carla, for your brilliant presentation.
Thank you.
Now, Carla, you will be here? Or
yeah,
it's okay?
Yeah, I'm here for at least the next slide. I have a case that's going to be starting soon, but I'll be here as long as I can.
Okay, thank you. So in that case, if you are moving forward, please let us know. Then we'll go to a question we'll answer to your question after the Subhanan Rai presentation. So this is next presentation is given by the Subhanan Rai, and he will talk on nanocrush. I will say that I have gone through the literature. This may be the second publication that is done by the Subhanan Rai. Another publication I've seen in nanocrush in the Canadian Cardiology Journal, Canadian Cardiology Journal, I think so. So can you start your presentations,
Thank
Dada?
you.
And just as people go forward with their presentations, maybe you can use the chat box and ask your questions so that we can answer them as we go.
Okay.
Am I audible?
Yes,
indeed.
So thank you, Afzalur, for your for the selection of this topic in this webinar. And nanocross stenting in bifurcation lesions is very close to my heart because I was practicing it for a long time. I am an old man practicing bifurcation for the last 20 years, maybe a little more. And initially, when there was a bare metal stent era, we used to do a bifurcation with bare metal stents, and we used to do the main branch stenting and side branch balloon dilatation and final kissing balloon. With that, we published a study and in Indian Heart Journal way back in 2004-05, and it was found that it was shown that the main branch stenosis with bare metal stent in bifurcation was around 14%, and the side branch stenosis with that bare metal stent and kissing balloon was around 22%. So with that in mind, we used to do our bifurcations with single stent and a provisional approach. But gradually, we have seen that around 5 to 10% of the non-left men and around 15% of the left men bifurcation requires upstream two-stent strategy. And it was more evident when we started left main intervention in 2006 in cases which were, we started left main intervention because it is a place where it is dominated by the surgeons. We started left main intervention since 2006 in cases where the cases are diffused by surgeons either due to age or comorbidities. And we have seen in that cases that side branch access, that is mostly the left circumflex branch, is usually difficult in most of the cases, and also they require a stent also. So almost in 20-25% of the cases, they are two-stent strategies, and with the side branch access first. So the available techniques in my hands during that time was modified T, where the side branch stent was placed just at the ostium of the side branch, and a mini crush stenting, where you need to place the side branch stent within 1 to 2 millimeter inside the main branch, and both depended on the judgment of the operator. And if you are a little on the judgment, you might miss the ostium, or if you are more into the main branch, it would create a long crush, and it would be very difficult for going for the next kissing balloon inflation. So with that in mind, we thought of something on paper to have a more easy, quick, and an affordable procedure. Affordable means in our India Bangladesh scenario, everything is spent from the pocket of the patient, so you cannot use a lot of stents, you cannot use a lot of balloons, so you have to be within the affordable price. So we planned out something on the paper, that is, we should go in the side branch first. We dilate the both the branches and go to the side branch stent first, and limiting the minimal protrusion of the side branch stent inside the main branch by one size smaller balloon. Like in case of 3.5 millimeter, we just used a 2.5 millimeter balloon in the main branch, which was inflated at the nominal pressure, and we pulled the side branch stent inside the main branch, and which is limited by the inflated main balloon in the main branch. And then we deploy the side branch stent and pull out the balloon from the.
Yes? Dada, can you show your slide? You're not sharing your slide?
Yeah, I'm sharing my slides. I don't know why it is not.
No.
Just a minute.
No. Slide is not coming.
Just a minute. I don't know why. Can you see my slides now?
No.
Now, can you see my slides? Can you see my slides now?
No. You have to
yes, we can see your screen. We can see your screen.
Yeah,
just launch your presentation and we can see it.
Yeah, that's it.
Yeah.
So
there you go. Now they're up.
Yeah.
Okay, you go ahead.
I was here. Probably I was here.
Yes.
And, then, after deploying the stent in the side branch, I pulled the balloon in the main side branch stent balloon in the main branch and did a high pressure kissing balloon inflation. That is the first case. And then I removed all the balloon and wire stuff from the side branch, put a main branch stent, and did a final kissing balloon. And we finished the whole procedure by 2 stents and 2 balloons. So that was the plan in the paper. And we did a first case in 2007. The patient was aged 79 years, is a diabetic, hypertensive, CKD with on hemodialysis dependent, and a severe left disease and multiple CAD, synthes score more than 50, ejection fraction 30%. And we presented this case in Delhi CSI. People in the audience, nobody looked at the case, but everybody was jumping up and down to curse the surgeon how they could refuse that case. Though the patient died after 9 months due to septic shock, that gave me confidence that yes, that is quite possible. We could do this with a 2 stents approach, and which is durable and can be represented. And so we were doing such cases. And though it was very difficult to get cases during that time, this is another case which came in my way in around 2009-10. This is a father of a doctor who was working in my unit, and his ejection fraction was 30% again, and this was the left main disease, and this is the right coronary artery disease. So we thought of doing a nano crash there, and it was the final result. And we thought that we would be presenting this case in India Live in 2010, and people there again, that is a technical conference, and people there in the panel fought that there is no crash, and I was criticized that there was no crash. Actually, it is a modified T. So we thought of a bench test, and that is also a very primitive bench test. I give all credit to my chief technician, Mr. Dipankar Sadhukan, for making a Y tube from 2 elastic tubes from the high pressure tubing. One is 3 millimeter and another is 2.5. I don't know how he could join these two by a super adhesive. And I asked Abhijit Chakravarti, the Boston Scientific sales manager at that time, to give me 2 expiry date stents. He was scared like hell, and he thought that I would be using in some patients. So he said that my job will be done. Doctor, don't do that. I said nothing else. I'm not going to do it in patients, and this will be just an experiment. Somehow, with that in mind, and we put you can see that we put a balloon in the main branch and pulled the side branch stent inside the main branch, and then deployed the main branch side branch stent. Then I pulled the balloon from the side branch stent and did a fast case. Then I placed the stent in the main branch. Then I recrossed into the side branch with another stent and balloon, balloon and wear, and did the final kissing. So it was the first bench test which we could do, and then we thought that we should do an in vitro IVAS to show that whether the orifice of the ostium of the side branch is elliptical or circular. And it is also a story how to do an in vitro IVAS. Everybody, we have done IVAS outside, but in vitro IVAS is not very simple. There is a lot of problems in that. Anyway, we could do in vitro IVAS and showed that there is a nice circular opening of the side branch ostium when you pull back the IVAS from the side branch to the main branch. And with that in mind, we in the next case, this is the case. I have presented that case in many times, so people have seen that. So this gentleman came to me and said that yes, I do not want to go for surgery. If you can do angioplasty, you can do it. And so we took the patient up for angioplasty. And this is the right coronary artery. We did the rota of the from left main to LAD. And then I finished the case with 2 stents by nanocrush. We did an IVAS in this case, and this IVAS showed that there is well above stent in the left main, and all the parameters found okay. And we presented this data. This is a angio after 1 year. This is a post angio, and that showed that the patient, stents are fine. There is no dystenosis. So this case I presented in PCR in 2014, and the Professor Wiens, he saw the case and he asked me that what is the amount of crash you see? I said it is a micro crash. He said no, it is a nano crash. So the name came from him, and he gave the name nano crash to this stenting technique. We presented the data in EBC in 2016, and in Rotterdam, and then in 2000 TCT AP in 2017. And after that, we used nanocrush in a lot of extended indications, like in acute coronary syndrome, and also we did that through radial routes. I can show you one case that this is an acute coronary syndrome. This lady came to us with severe unstable angina and not responding to any drugs. So we did nanocrush. This is the right coronary artery. So we did the nanocrush, and this was the final result. And she is doing very well now. And also we did one case, 2 cases from radial artery. And this is another case. This is a gentleman who came to us for, again, acute coronary syndrome. He had a stent in LAD, and also he had a stent in RCA before. He is diabetic. He is hemodialysis dependent. He has a heavy fistula on the left hand. And this is the right coronary artery. This is fine. He also had peripheral artery disease, and this is the iliac. There are 2 pajama stents in iliac arteries, and also his peripheral arteries are bad. And actually, he had a below knee amputation of both the legs. So these gentlemen, I had only one option left, that is the right coronary artery. So I went through the right coronary artery with a slender shade of Terimo and put a left guide, 7/8 left guide, and did this nanocrush. So with that, we published our data in Asia Intervention, and this is the distribution. You see, these are the 42 cases were published, and this is a very high risk cases because diabetes is present in around 80% of the cases, and hypertension maybe 85%, and there is a very high number of left main cases, around 40% left main, and calcification was there also in some cases. And this is the MACE rate. With that, with this high risk, disease, our MACE rate was 7.4%, which is less than 10%. And also there is target vessel revascularization was in 4% around, and there was no stent thrombosis. So, ladies and gentlemen, so I think basically, our initial cases are very closely followed. I have seen that with case one, case 2, which I have already shown you, that he is still doing well. On and off, he had left ventricular failure, which was managed in OPD basis. The case 3 had a subdural hematoma operated in 2018 because during that time we had an angio which was fine. And during that time his DAPT was stopped for 1 month. He expired due to cerebral stroke in 25 June this year. And so all my 42 cases are well connected, and I can I take care of them. And with that, I think this is an easiest and quickest procedure of all the crash families. It is safe and with durable safety, but it needs a multi-center randomized control trial to compare with DK crash and Kurot. I can vouch one thing: it's a very easy procedure and safe procedure. Thank you very much for patient hearing.
Thank you very much for your presentation. Now, this is a nano crash. I think so. We will discuss it later on, as Robin told it that. So, can we go for the presentation of the Nishina? Definitely, this is a good technique. I have gone through the literature. Still, I have not get the opportunity due to the Corona crisis, but I will try to do it your nano crash. Okay, we'll discuss later on. Now, my friend Nishina from Japan.
Okay. Hi, everybody. I'm Hidetaka Nishina from Japan, and it's my great honor to be invited as a speaker from my good old friend Afzal Rahman. And okay, well, the two presentation was quite impressive. I really enjoyed it. So, can you see my slide?
Yes.
Okay. So my talk is related to Ibis use in complex and bailout situation. And here's my disclosure. So it has been reported that routine use of Ibis improves outcome. There are two randomized trial, Ibis XP trial and Ultimate trial, both show the Ibis guided PCI is superior to angiography guided PCI. And now, intracoronary imaging has given the 2A recommendation in ESC guidelines. However, those benefits of Ibis were mainly driven by stent optimization, which includes stent expansion and stent apposition and edge problem, like dissection. But my question is stent optimization all we need in our daily practice? The stent optimization is needed only at the end of the procedure. But I would say it's no. The role of Ibis in daily clinical practice is not only for stent optimization, but also for procedure planning, maybe prediction of possible risk and the planning based on that prediction. And of course, we need Ibis to bail out from difficult situation and complex lesion. So in this talk, I would like to share the case-based learning. And, these are not the chip cases, but these chip, I think will help, especially in the chip case. So the first case was how to predict and prevent no flow phenomenon, because chip cases are frequently associated with reduced LV function. Therefore, the further deterioration of LV function may impact outcome immediately and significantly. So here's one case this is stable case, RCA proximal lesion. Can you see the Ibis movie?
Yes.
Okay. So as you can see, the vessel is large. It's over than 4 millimeter diameter vessel, and there are lots of plaque with a signal attenuation behind the plaque. So this is a typical case for attenuated plaque. An attenuated plaque is characterized by hypoechoic plaque with deep ultrasound attenuation or shadowing without calcification. And this usually represents large lipid pool or necrotic core. And of course, this is more frequently seen in acute coronary syndrome. However, this can be also seen in the stable disease patient. And the larger the attenuated plaque is, especially when shadowing begins closer to the lumen, which means the fibrous cap is very thin, the higher the risk of no flow after PCI. Our Japanese colleague has reported that the patient or lesion has attenuated plaque length equal or greater than 5 millimeter, the incidence of no reflow after PCI is significantly greater when compared to those lesions with attenuated plaque length less than 5 millimeter or those lesions without attenuated plaque. And in this particular case, actually, when you see the longitudinal Ibis image, you can see the signal attenuation length was 20 millimeters. So it's quite long attenuated plaque. And actually, the vessel was large. So that means the plaque burden is also very large. With this very significant shadowing, that means this patient is extremely high risk for the no reflow phenomenon after stenting. And how to prevent it? There is a vampire study, in which study the investigators randomized 200 patients with high risk feature of no reflow to the PCI with distal protection and PCI without distal protection. And what they found was the incidence of no reflow phenomenon was significantly reduced by using distal protection when compared to no distal protection. And most importantly, this is in hospital adverse event. There was, with distal protection, the incidence of cardiac arrest, cardiogenic shock, was significantly lower. It was 0 on the distal protection group when compared to the 5.2% in conventional treatment group. Imagine this patient has kind of very severely reduced LV function. It's going to be really critical for that kind of patient. So it's very important to predict and, if possible, prevent no reflow phenomenon after PCI. So in this particular case, we placed a distal protection device, filter wire, at the distal RCA and deployed 3.5 millimeter long drug-eluting stand, followed by a pretty large 4.5 millimeter non-compliant balloon. And I hope that movie works. After post-dilatation, you can see the reduced antiquated flow. However, this is partially due to the filter itself. So after removing the filter, the flow was restored, and the patient didn't have any adverse event in this case. Okay, and the second case was regarding the calcium, because the calcium is one of the most challenging obstacles, especially in chip PCI patients. Okay, so the calcium, calcified plaque can be seen as a very bright echoes with acoustic shadowing of deeper tissue zones. And this is one case, right? This patient presented to the emergency department with a symptom of unstable angina. However, I don't know, but the physician ordered CT coronary angiogram, which found diffuse RCA disease with only small calcification in this distal RCA, as you can see on the angio. But, actually this case looks pretty straightforward. So should we go with direct stenting or we need lesion modification? That was a question, but we cannot answer this question. It looks pretty easy case. However, when you see the IBIS, we found there was a circumferential calcium, although it was very, very short segment. See here, you can see the calcium. It's less than 2 millimeter in length, but the calcium was circumferential, 360 degrees. And there was one study, a randomized trial, PREPARE-CALC trial, which randomized 200 patients with severely calcified lesions on angiogram into the lesion preparation with modified balloon, or scoring a cutting balloon followed by drug-eluting stent implantation, or rotational atherectomy, caused by drug-eluting stent implantation. And what they found was rotational atherectomy, was resulted in significantly higher initial strategy success. And this was driven mainly by the higher rate of crossover in modified balloon arm, which means in modified, in the patient assigned to modified balloon, 16% of the patient required rotablator because of the undilatable lesion. But in other words, we can state that the 84% majority of the patient of severe calcified lesion can be treated with modified balloon only without rotablator. So I think it's reasonable to start with ballooning, modified balloon, before rotablation. So, to save time, to save money, right, and to reduce complication associated with rotablator. So in this case, we started with ballooning. We used a Squaflex scoring balloon, 2.5, but the lesion could not be dilated even with high pressure 20 atmosphere. So we crossed over to rota in this case. We started with 1.5 rota burr. However, even after 1.5 burr, the lesion was still undilatable with the higher pressure using the same balloon. So we went to 1.75 rota burr. And finally, we were able to dilate the lesion with same scoring balloon at 20 atmosphere. And when you see the Ibis, this is very important finding because this is the baseline on the left and after rota 1.5 millimeter and after rota 1.75 millimeter. And finally, on the right side, after Squaflex dilatation, now we got several calcium fracture. And this means this is a key to adequate stent expansion. When you got this sign on the Ibis, now you're ready to stent because you will get sufficient stent expansion. But without this, you might end up with underexpanded stent, which would be a nightmare. So in this case, as you can see, we got pretty good stent expansion. So the key point of this case is, I think, because of the Ibis, we were able to avoid direct stenting, and we were able to avoid underexpanded stent. It's because once it's deployed with underexpansion, it would be really hard to dilate it with a balloon. So let's go to the third case. And this is, again, for the patient with severe reduced LV function or, poor hemodynamic status, we don't want to lose even a single branch. So I'll show just one case with a circumflex disease, and I would call this marginal branch as main branch and this circumflex, distal circumflex side branch. And after, main branch ballooning, patient suddenly complained chest pain, and there was a positive EKG changes. And what we found was there was a very nasty spiral dissection with reduced antegrade flow in this side branch after main branch ballooning. Okay. And we had to, advance guide wire to this side branch to save this patient, save this side branch. However, we had to advance guide wire to 2 lumen, not in the false lumen. So we did Ibis pullback of the main branch at the level of bifurcation. And you can see, and for this kind of Ibis image, you have to really, what we need is meticulous interpretation and understanding, then make a strategy based on the, information you obtain from Ibis imaging. So when you look at this very closely at the distal point, you can see the white band here. This is actually the intima, and black band here, this is media. And media, you can see the media surrounding this Ibis catheter. So this is the vessel structure. On the other hand, you can see another lumen on the upper side, but there is no this kind of structure on the wall. So this is a false lumen, right? And when you go a little bit proximal to it, you can see the disruption of vessel wall, and this is the entry of false lumen of the side branch. So from this information, now you can understand that the false lumen, entry of the false lumen is located proximal to entry of the true lumen. And where we want to go is, of course, true lumen. So how to cross the wire to true lumen? So our strategy was like this: advance the guide wire, of course using double lumen catheter, to the distal main branch, and then pull it back slowly until it gets the entrance of true lumen. And on the right side is the actual, the cine image. So at this point, the tip of the wire was in the distal main branch, and we put it out. And then we were able to select the true lumen of the side branch. Of course, we confirmed by Ibis after that. And after that, what we did was, instead of putting a stent, we used a cutting balloon at the distal side branch to create re-entry. When you create the re-entry, the blood flow can go across both lumen, true lumen and false lumen, and the patient, symptom relieved and no EKG change. So we just finished this procedure by putting 2 long drug-eluting stents to the main branch. We didn't want to put the small, we didn't want to place the stent to this small side branch. Okay, the fourth case was we should limit the contrast volume in case with chronic kidney disease. And actually, there was a publication from Dr. Rahman recently with zero contrast angioplasty of LAD ostium by Merkel wire technique. So actually, we did the same thing because this patient presented to our hospital a couple of days ago, already in Wednesday morning, so just the day before yesterday. So this was a very old, 92-year-old male with end-stage kidney disease. And he had previous history of mid-LAD stenting in 2016. So this was a picture, from 4 years ago. And surprisingly, his serum creatinine was 7.1 milligram per deciliter. However, to whether or not to introduce hemodialysis in this 92-year-old was yet to determine. But he's a very active, independent gentleman without dementia. So in Japan, he is likely to receive hemodialysis in near future. And this time he presented to the emergency department for chest tightness. And the EKG showed new ST depression in chest lead. And the echocardiogram showed new regional wall motion abnormality in the anterior septal walls. And this was not present a week ago. Yeah, actually, the patient presented to the emergency department for the same complaint a week ago. But at that time, no evidence of ischemia was found and he was sent home. But anyway, now we knew he had something wrong in his LAD. But the problem was his kidney disease. So what we did was we did Ibis without angio. Because we know his coronary anatomy from 4 years ago, we crossed the wire to the LAD and checked with the Ibis. And what we found was here, the previous stent was patent without no significant in-stent with stenosis. And proximal to that, there was a severely calcified lesion, very eccentric calcified lesion, and tight stenosis in the proximal LAD, involving the ostial LAD. You can see the circumflex here. However, we didn't want to, in this case, we decided to start with modified balloon because we didn't want to use a rotablation in this patient. So fortunately, the lesion could be dilated with scoring balloon. And this is the Ibis examination, instead of coronary angiogram. After the ballooning, and what we see on Ibis was we got some gain in the lumen in this calcified lesion. So we actually proceeded to the stenting, but we still didn't want to use any contrast for this patient. So what we did was Ibis and guide wire marking. So we placed the imaging core of the Ibis, under the navigation of the Ibis image, we place the imaging core at the LAD ostium, which can be confirmed on Ibis imaging. And we, check the relationship to this guide wire advanced in the marginal branch of the circumflex. So here's the Ibis and guide wire marking. And we, position the stent according to this finding, then deploy the stent. And here's the final Ibis. Although there was some mild underexpansion, however, the minimum stent area was 5.9 millimeter square, so it was acceptable. And the stent positioning was perfect without any compromise in the circumflex ostium. So we were able to treat this patient without any contrast usage. So this is very important, using Ibis as a positioning tool, not only for the lesion characteristics evaluation. So my take-home message, is actually I have much more cases, but because of the time limitation, I limit the case for these 4 cases. So intravascular imaging is beneficial not only for stent optimization, but also in complex and bailout settings. And fundamental knowledge of the vessel structure, including intima, media, and plaque characteristics, and meticulous interpretation of the images can facilitate complex procedures, which are very common in CHIP PCI. And to apply those advantages of Ibis to complex cases, I think daily usage of Ibis is very, very beneficial. Thank you very much for your attention.
Thank you very much. This is a very great talk, and we are everybody here. So let us start from the Robin. Can we start from the Carla? My friend, you focused mainly on the training and the skill setup for the fellows.
Not just for fellows, for anybody interested in getting involved in complex PCI.
If you would like to establish a program of complex intervention high-risk cases, then what kind of setup that you would require? Am I correct?
Yeah.
Yes. Because you can give some guidelines, some suggestion. Maybe you will be the proctor of the very soon in the future when the COVID is gone up. We will invite you as a proctor in Bangladesh, especially. So, what kind of setup do you recommend in our situation? Because you have also experience doing hands-on training in NICBD and other places. So, what do you think about this? What kind of training?
So I think that's a challenging question to answer here, but there are a couple of big bubbles that you have to keep in mind when you're setting up one of these programs. Do you have the institutional support that you need? So is the institution willing to give you the equipment you need? Do they have the facilities, the radiation optimized cameras, the availability of Ibis, the wires, the microcatheters, these kinds of things? Is there a buy-in from your colleagues? So your non-invasive colleagues who are going to end up referring you patients for these kinds of things, do they believe in what you are doing? And if not, can you educate them? Do you have adequate support for the aftercare of these types of patients? Because we've learned with real CHIP cases that they tend to get sicker before they get better? And then, do you have a mechanism through which you can either identify these patients in the community, second opinion clinic, high-risk PCI clinic, these kinds of things, and then follow them up in the community? You need to put all of those major bubbles in place just to do the cases. But there's a lot more to the story than just doing the case. It's making sure that the procedure is financially viable. So some mechanism through which you're tracking how you're doing the cases, how much equipment you're using, what that equipment is costing, and whether or not there are areas where you can get more efficient. And then a way of and this is probably the most difficult part, a way of communicating to patients and their families that what you're suggesting, even though it may be an expensive procedure, really has benefit for them, and here's why, and you help them understand some of the fundamental data. So I guess the summary of that is you need a way to identify the patients. You need a way to see them before so that they meet you and they understand what you're going to do. You have a true informed consent discussion and they understand why you're doing what you're doing. You have the facilities you need to do the procedure, and an institution that's willing to back you in doing the procedure. And then you need the institution to understand that you're going to need resources to be able to do these things, and they have to be supportive of that.
Robin?
Yeah, I think in addition to what Dr. Kalra said, I must add to some joke that clearly, as we have seen, I would refer to the second case of Dr. Roy, and that was a really tough case. Other than the other two cases, the second case I found was not really complex. The one, he took the rota through that. Was it second or the third one? I think the second one. Third one. So that is the case which is really tough. So I must say, I'm sure that Dr. Roy did not use any kind of support device like ECMO or this kind of thing in such case. Am I correct?
Can you be a little louder? I'm not.
What I'm saying that in that case where that was a complex case, very critical, I would say, distal left main, as well as you do the rota, but you didn't use any support device like ECMO.
Yeah, that's right. I didn't use any support because of the fact his ejection.
I'm not questioning that. I'm not questioning that at all. The reason why I'm saying that this is the kind of threshold that we have in this subcontinent, that our threshold of going ahead with the kind of device support is very high. Therefore, the operators in this subcontinent, I personally feel, are very competent and very accomplished to take up such really, really challenging cases. But I have to say that to establish a program, this is maybe a one-man show like Dr. Ray's show or maybe Dr. Abdullu's show. But, as a group, as a team, as a program, we need to work a lot to develop the other areas. For example, the critical care specialist, the cardiac anesthetist, even the technicians, the paramedic staff, even the hospital management admin team. So it is much more beyond that what you are doing, as you said very rightly. But everything is doable in this. I'm sure this is also doable.
So if I can comment, there is a misconception that CHIP means hemodynamic support. And I've tried by illustrating the nature of the skill set that's necessary to identify that hemodynamic support, or the use of hemodynamic support, patient selection, these types of things, is only one small part of what is the whole complex and high-risk PCI skill set, right? Does that mean that every rotablation with an abnormal EF needs an Impella? Absolutely not, right? Or a balloon pump, or ECMO, or whatever. Does that mean that there are cases that you're really not going to get done safely without hemodynamic support? Yes, that's also the case, right? And that's why we're learning more and more about these types of patients now, because we never used to do the cases before. Now we can do them because we have the resources available. I think the key is, I do agree with what you said, though, in on a fundamental basis, which is that you have extremely competent operators in these, in Southeast Asia, because of many of the reasons you've discussed, and also because you guys have incredible volumes at your institutions. And for that reason, I think that a community needs to rise up. Operators that are partnered with one another across these geographic areas to be able to influence government and influence industry and influence these types of organizations to start putting more resources into the care of complex patients. This is the elephant in the room, right? It's a population that's getting bigger and bigger day by day, and in environments where patients are either forced to pay the entirety of their care themselves, or they don't have any sort of insurance support or what have you, it becomes very difficult to get them the treatment that they need. This is a system problem. This is not an operator problem. And the people that are going to listen to you, the governmental organizations that are going to have to modify things are going to have to modify things based on the message from operators such as yourself and the others on this webinar, who are learning the skill set, who recognize what it takes, and who are simply sick of seeing their patients not treated appropriately.
Right. I think
can I make a point here?
There are two questions.
Yes.
One for Dr. Roy. Is there any angle for this nano crush is there any difference of this crush of nano versus the other crush, angle-wise, anatomy-wise?
So basically, before that, I want to say a few words about Sanjog. It is a wonderful lecture that made a huge subset into which is almost a chaos into a method. What I perceive from his lecture, it is not the skill set which is important. It is the skill set of understanding of the disease. Whether that man should be doing well with hemodynamic support, whether that man would be fit enough to have a large bore catheter, how to go by that, how to repair that large bore catheter which was placed in the femoral, everything inclusive. So chip is a different entity, and Sanjog's lecture gives us a nutshell view that how a chip can be approached, and what knowledge you need to go for a chip to become a chip operator. So this is a new subset whatsoever. It is not just a skill set or anything. It is a huge skill set including physiology and everything. So with that, I'm coming to my very straight, simple answer. Nano crush is the only only technique in the crush family which I have seen that can be used in any angle. And if you look at my cases, there are 60-degree angle where we use nano crush, and also in 90-degree and 110-degree we use nano crush, because the problem of angle is when you put the side branch stent in, if it is an acute angle, the side branch stent will move more into the main branch. If it is more than 90 or 90, it will more than 90 maybe, it goes out of the side branch. So there is a chance of missing side branch ostium if the angle is more, and if it is the more acute, then it will encroach more into the main branch. So giving a limit by inflating a one size smaller balloon in the main branch, you can limit the entry of the stent inside the main branch, and you can calculate, and it can be done in any angle.
Do you have any data to support this statement with the nano crush technique? Any literature?
Yeah, we have published our data in PCR in a Euro intervention that is in 42%, 42 cases, and our MACE rate is 7%, and no stent thrombosis whatsoever.
Excellent.
Robin, what I understand from his technique, that it is the combination of the tap technique and the nano crush, because it is more or less like that. So taking the advantage of the tap technique and taking the advantage of the decay crush, the nano crush in between that, because there is a small protrusion beyond the ostium, but the technical problem is that to put the stent beyond the ostium sometimes may be difficult, and he has to take so many views to figure out that. That's right.
But do you think the imaging technique?
Yeah, that's a great place to use Ibis.
Reduce this.
Yes.
Mm-hmm.
We have done an Ibis, in vitro Ibis when we did that, and we showed that the stent which is compressed, it is compressed. It is not crushed. The stent, side branch stent, which is extended into the main branch, is actually compressed. It is not crushed, and actually flared by the side branch balloon and the main branch balloon when they are inflated simultaneously with a kissing balloon, like in a kissing balloon fashion. So actually, the side branch stent is compressed as well as flared, so that the nose ostium is missed and there is no extra metal inside the main branch.
So when we look at these various bifurcation techniques, though, I mean, I think the basic principles that we're trying to satisfy are make sure that the stents are well expanded and that the ostium is big, of the side branch, so that you have no flow impediment. And number two, make sure that the ostium is covered in drug, because that's where you get your eddy currents, that's where you get your irregular flow, and that's why restenosis tends to happen there. And so whether it's a nano crush or a DK crush, I mean, the evidence would suggest that DK crushes are the quote best two-stent bifurcation technique. But your point's well taken in that if you use imaging guidance and you place your stents appropriately, you flare the ostia so that you have large minimal stent areas on IVUS. Those are probably the largest determinations of whether or not you're going to end up getting restenosis. And we know from all kinds of IVUS and OCT studies that oblong stent expansion is not the end of the world. There's nothing wrong with it as long as you have a big minimal stent area. And and it's that minimal stent area that drives the robustness of flow. So nanocrush seems like a very reasonable technique, so long as you get imaging guided optimal expansion of the stents at the ostium and in the main branch.
So do you think
used imaging like IVUS in almost all the cases of left main, and we have shown that there is quite significant stent deployment and achievement of the area by intravascular imaging. And our long-term study also shows that there is less MACE. MACE is very little.
Yeah. So, but that's the point, right? Is that what you've done is use the various technologies that you have at your disposal to optimize your stent result. You're not walking away looking at an angiogram where two stents are deployed and they look okay. You've got reasonable flow. You're doing what you need to do to make sure that you've got optimal minimal stent areas, and that's really why I think your small cohort of patients has good outcomes, right? And of course, because you're a very experienced operator. Yes. I think the message is that, right, is when you're going to do these things, learn them carefully, but then make sure that you use everything you need to use to be able to get the optimal result, because these are the types of patients where they're least tolerant of bad outcomes. Someone who has bad calcific disease and multivessel coronary disease is not going to tolerate a stent thrombosis. They'll die. So you've got to do everything you can to make sure that your result is perfect when you walk away.
Okay, thank you. So do you think that every time the stent position in a nanocrush has to be done with the guidance of the IVUS?
Not really.
Left main, really. That's what he's trying to say.
Not really. The stent position is maintained by the balloon, but you need the IVUS to see that whether the stent has been deployed nicely, whether you need a pot or with a larger balloon, or whether you need a one size bigger NC balloon in the side branch for the kissing balloon. So these are small things which are usually maintained by, and also which are guided by the intravascular imaging. Otherwise, as a technique, it is so simple that once you start it and you will never forget that. It is simple. It's just like
respectfully to my colleagues, though, as we heard from Dr. Nishina, I mean there are multiple randomized controlled trials that show intravascular imaging and routine PCI results in hard outcome differences. There's no less than 9 randomized controlled trials across multiple patient subsets. And so, I mean, this is it, right? This is when we put foot to pavement. Let's not pretend. If you're going to do this, let's do it right? Your bifurcations are going to be your high risk patients by definition. That's a complex anatomic subset. And these are the patients that are least tolerant of bad outcomes. I realize that IVUS costs more, and that's why I say that as a community, we need to get together to make sure we do something to get the technology in the hands of operators so that they can use it appropriately and get the best outcomes for patients. That's really why we're doing what we're doing. And, and so I think whether it's the left main or it's the mid LAD or it's the mid circumflex, if you know you're getting better outcomes using intravascular imaging, we should probably be using intravascular imaging. It's like using nothing but M mode echo when that was all that was available, right? All we had was M mode, but now we have 2D echo with 2D pictures. I submit to you that a parasternal long axis view or an apical view is indispensable, and it's not just good enough to use an M mode anymore. That's angiography now, right? We just need to use all the information that we have at our disposal to get the best results.
Okay. My point is very simple. There is no doubt in it. There is no iota of doubt that intravascular imaging in the complex angioplasty subsets is absolutely indicated. There's no doubt in it. But what I wanted to impress that the stenting procedure does not require an IVUS imaging.
I understand.
After the stenting procedure, you definitely need an IVUS to optimize stent deployment and everything.
Yeah. Yeah, I understand. I guess
yeah.
the point is that we just need to make sure the results.
Final result.
Running out of time,
So now we can go to the Nishina. And Nishina, thank you for demonstrating my case. Actually,
thank you very much.
My friend Carla was the proctor. He trained me in the zero contest. Then after leaving from my country, I have done so many cases, and this is the case actually a little bit unique technique, and that is published in the journal. And thank you for sharing that. And you have a lot of contribution in the imaging in Bangladesh. I will say that the Gary Stone is the number one, and he's the boss. He's the penetrating lot of after demonstrating his elegant lecture. And also you have a contribution for the development of the imaging in Bangladesh. I must appreciate that. Now the thing is that during the use of the IVAS, in all the time we have do the IVAS pre and post, or sometimes we can do it only post. What do you think about that?
I think for stent optimization, only the post IVAS is good enough. But however, for example, for the bifurcation to stenting, I think intravascular imaging is also important to confirm the course of side branch wire, after we cross of the side branch, because usually, the left main stent may be, molar post, and stent may go the wrong way, to the side branch, coming from the outside of the left main stent and then going to the side branch. And without knowing that, if you apply the final kissing balloon, you will get in trouble. So it's always, important. Maybe one way is just apply the pot before recrossing the wire to the side branch. And another way is check with intravascular imaging if the course of the side branch guide wire was correct. So I think, especially in complex, PCI, bifurcation, calcified lesion, or dissection, case with dissection, I think intra-procedure imaging is a key to the success. And these are not going to be in the evidence.
Here's a question for you, Dr. Nishina.
Yep.
In relatively simple question, in which case you select IVAS, and in which case you select OCT?
That's a very good question. It's in Japan, we can use both technology, and it really varies. It depends on physician's preference. I personally prefer IVAS over OCT. However, for the case with severe calcified lesion, OCT, with OCT we can measure the calcium thickness, and it gives the idea if we need water or we need ballooning, just swelling balloon. So actually for the calcified lesion, I prefer OCT over IVAS. And also for the in-stent restenosis, I prefer OCT. But other than that, I actually prefer IVAS. But both technology, really, I think improve the outcomes of the patient. So it really depends on the preference, I think.
Dr. Subhanandra got a question. In nanocrush, do you need to flare the stent ostium before bringing out the side branch balloon? Do you need to flare the stent ostium before bringing out the side branch balloon?
Basically, the technique is first dilate both the branches nicely with balloon first, or anything. So prepare the bed nicely. Then you put the side branch stent at nominal pressure, and then flare it with the balloon itself, pulling the balloon into the main branch nicely, and then do the case. Then put the main branch stent and do a pot. We have included pot recently. Do a pot. After doing the pot, we go into the side branch and do the final kissing, and end the case with another pot. So there are two pots, and actually we flare the side branch stent ostium by the stent balloon itself.
Good.
Two pots and two keys.
So
right, okay.
The difference with the decay crush and the nano crush, in the decay crush, they first crushed up stent by the balloon at the main branches, but in the nano crush, he take the balloon from the side branches and the first kissing balloon.
There are two very important differences between decay crash and nano crash. In decay crash, you do not have an idea where you are entering into the main branch. There is the decay crash. In decay crash, you just enter the main branch with the side branch balloon arbitrarily and deploy the side branch. Then the side branch stent, and then come out with the balloon and wire from the side branch and crush the side branch stent with the balloon in the main branch. So again, you re-enter the stent, and sometimes it takes a long time, and sometimes it becomes difficult to go inside the side branch through the crushed side branch stent. But in our case, as we are limiting the metal load inside the main branch by inflating one balloon in the main branch, and we are never losing the balloon and the wear from the side branch before first kiss, our job becomes quick and easy.
Easy, right? Agreed. I think we may have to go because it must be for Dr. Nishina. What is the time? It is 9 o'clock or 9:15?
Yes.
9:15. 9:15. Quite late. So, Dr. Abdul, there is a compliment for Dr. Nishina. Thank you, by Dr. Zillur Rahman. Thank you, Dr. Nishina, for your excellent demonstration.
Oh, thank you. Thank you very much.
Last year, he attended your robust course organized by Boston Scientific at Miyazaki. Dr. Abdul, would you like to conclude?
I think so. Shubhanan Rai, Dada, now you will conclude.
Okay.
On behalf of me, Shubhanan Rai will conclude.
At the end of the procedure, it was a wonderful webinar, and I think everybody has earned a lot from the lecture of Sanjog, but particularly Sanjog and Nishina. They have shown so many wonderful cases, and it is from actually my all praise goes to Sanjog Kalra, because he has made some methods. He has tried to make some methods inside the madness, inside the chaos. In a cheap procedure, is actually chaos, where the patient is bad, where the situation is bad, where the anatomy is bad, where they have to make a method, it's difficult. And it is the beginning of a era perhaps of the cheap. And also I would thank Afzalur and Robin Chakraborty to create BEAT, and also my friend Mamun Jaman. They have created BEAT for so many people who has learned a lot of things from these webinars, from these conferences, which BEAT held for so many years. And I can see a lot of young physicians who eagerly wait for the BEAT to happen. So thank you very much for everybody, and it's a wonderful session. Thank you very much.
Thank you very much.
Thank you, Nishina. Okay. Thank you, my friend.
Okay,
Nishina.
thank you. Okay.
Thank you very much.
Thank you,
Dada. Thank you,
Robin. See
Robin.
you all very soon. Okay, thank you.
Thank you.
Take care. Very soon.
Thank you.
And Dada, I am waiting for your last number of the Nano Crash. Okay. I'm waiting for your.
I know. Also, I seek your help. Do a lot of cases so that it will be a multi-center trial.
Yes, I love to do that. Okay, thank you.
Have a registry of this Nano Crash technology in
this. Yes. I'll be happy for the part of that. So I'm very excited to be the part of that. And thank you, Nishina. Thank you again. Okay, thank you very much. And hope to see you next webinar. Hope to see you next webinar, everybody. Okay, thank you. Thank you.
Bye bye.
Bye bye,
everybody.
Bye bye, everybody.